So we're going to talk about predictors of aortic risk beyond size. So as many people have said, and I think this is pretty funny because, sorry, my screen is going crazy. This is really funny because the last speaker did the same thing, and sort of this is our ever dilemma, right? We see this patient in clinic and we say, what do we do about this patient? Do we start medical therapy? Should we care? If this is a tetralogy of Fallot patient, I'm probably not going to care. Do you start medical therapy? Do you operate? And we're going to talk about some non-traditional markers of risk. So we all know about aortic size, and we'll go over a couple of those, but are there other ways we can assess the patient? So what we're worried about is, what is the patient's risk of dissection or rupture? Oh my gosh. Is medical therapy indicated and is surgery indicated? And can additional information help with these decisions? So as we know from looking at different imaging in our genetically mediated aortic patients, there's a lot of phenotypic overlap between different mutations. We see patients who have aortic dilation of the root, of the ascending, these elongated arches. Some of them manifest as dissections. We can have PDAs, but how do we make determinations when we see these images? And again, this slide has been showed multiple times. Aortic size is a poor predictor. And actually, one of these papers, actually two of these papers, were used to argue that 5 is a good cutoff. But I'd argue if you look at the spread, if I'm the person who didn't have a dissection until 8 centimeters, maybe I could have gone 30 years without a root replacement. You know, so maybe we need to move beyond size, as many people have talked about. So we do know that in certain mutations, so this is from the Montalcino Consortium, comparing TGFBR1 and TGFBR2 at size at dissection, you can see that there's a difference, but still there's quite a big spread. So I think I feel like research in this area has been very simple in the past and said, what's the size of your aorta? And maybe the size depends on your mutation, but maybe we need to think in a lot more complicated manner, but that's challenging. So challenges in setting risk factors. Now we're getting very, very far from basic science into my comfort zone, which is clinical outcomes research. But I think many people want to say, does this predict death? Does this predict dissection? But it gets a lot more complicated in that every prediction algorithm is multifactorial. Right? If we just said genetics, you have a TGFBR1 mutation, you had a TGFBR2 mutation, we knew you're going to dissect, then we would just operate on everyone. But we're already using mutation and size to make most of our decisions today. So the problem is we actually need to use a combination of static variables and dynamic variables, and we're modeling in research, we don't account for this. It's really easy to model for sex. Are you a male or a female? That doesn't change from the day you're born. It's easy to model for what your affected gene is. But what about your age? How are we modeling it? Sometimes we model it, we'll do a Kaplan-Meier, that takes into account age. But what about aortic dimension? Aortic dimension changes. Almost every study that's been shown has the aortic dimension period at a single time. How do you model it over the course of a lifetime? How do you model hypertension? Is it treated? Is it untreated? How about pregnancy history? If you look at most of the papers that look at pregnancy, there's a few that do it right, but they'll say, were you ever pregnant, were you not? And they go back to when you were 13 years old. Well, you weren't pregnant the whole time from 13 to 52, but that's how a lot of the statistical modeling is. And I think we really have to think about how a person's risk changes every day of their life as we're doing this. Now, one thing that's been brought up is, so as we're starting to move to different predictors, is indexing for aortic size, especially in the last 3 talks. And one argument, as a pediatrician, I do love Z-scores, and I think like Dr. Bradley said, when you look at Z-scores, you say, okay, well, how badly dilated is this? And I think it is really helpful in that sense. However, as our last speaker said, it's terrible for predicting dissection, because if you look at Z-scores, this is our Marfan cohort, and this has been replicated in several other studies. Z-score doesn't really change over time. It might go down a little bit if you're aggressively treating, but if it doesn't change over time, you can't follow it to predict risk, right? So most of my kids with severe Loeys-Dietz, severe Marfan, mild Loeys-Dietz, they have the same Z-score today, maybe it's like a half a Z-score lower, than they had 5 years ago. So you have to have something that's changing and getting worse to model it to predict dissection. So, and this is our we just submitted this to the ACC. These are our patients with TGFBR1, TGFBR2, and TGF-beta2 mutations. These are the red is TGFBR2, the green is TGF-beta2, and the blue is TGFBR1. As you can see, these are their absolute dimensions. These are their Z-scores. They all start in sort of a different plane and then just stay there, with the exception of these 3 really severe patients with TGFBR2 mutations. But their Z-scores, even though some of these are quite severe, this is Z-score 4, we've got 5, their z-scores stay pretty flat. So unfortunately, z-score is not a great predictor of who's gonna, I mean, you might say one day your risk is higher of dissecting, but if you're trying to manage the patient day to day, that's not really helpful because when they're 2, they have a z-score of 6. And that's probably not the right time to intervene. So I can't give a talk without talking about tortuosity, for those of you who know me. So one of the predictors that I've found really interesting, and in fact I think it's one of the only non-size predictors that's been shown to predict dissection, is vertebral artery tortuosity, and probably this is just a sign of all sorts of arterial tortuosity. This is a paper from a few years ago where we looked at the vertebral arteries in patients who, most of our cohort, it was 90 children, it was a pilot study, mostly with Marfan syndrome, but some patients with TGFBR1, TGFBR2 mutations, and a few other conditions. And we measured the tortuosity of the vertebral arteries really easily from an MRI. We just took the absolute length in 3D space, took what the length should have been, and took the excess ratio, the excess percent, and that's called the VTI, or Vertebral Artery Tortuosity Index. And here's just some examples of some of the patients in our study. This is a patient with TGFBR2 mutation, and this is his mother. This kid was very severely affected. She was very mildly affected. She was 52 with a normal VTI. Normal is less than 10. This patient has Marfan syndrome, and this patient has Loeys-Dietz syndrome. So you see that we have a whole range of VTI. And just of note, tortuosity, if you start paying attention, is present in a lot of different conditions. And in this model, when we looked at this cohort, we looked to see we did Kaplan-Meier estimates for risk of any dissection or death. And we put it in 3 groups, and a high VTI, less than 10 was normal, a high VTI was associated with higher risk of dissection and death. And when we put this in a multivariable model, yes, z-score was important, but actually diagnosis fell out. So it sort of didn't matter what the diagnosis was, but the strongest predictor was your VTI, and the second strongest was your baseline root z-score. So why do we think kids have tortuosity, or adults have tortuosity? Well, the overarching hypothesis is that there's abnormal lengthening in a fixed space, and this lengthening and lengthening and lengthening gets there, and the vessels can't go anywhere, so it's compressed and has tortuosity. And why does this happen? Well, we think maybe it's a maladaptation to stress. Maybe the vessel doesn't know how to respond and lengthens to try to reduce stress. It might be that the wall has a lower manifest tension, and so then it sort of relaxes. There has been some hypothesis that this is due to increased TGF-beta activity, but I think recent literature suggests that's probably not true. The questions after that pilot study, we said, wow, okay, if I see you today and you have high tortuosity, I think that you're at higher risk of dissection, but what does that mean? How does it change over time? How to use it in clinical care? Does the degree of tortuosity affect the size of the aortic dissection? So our hypothesis was that tortuosity increases with age, right? We know that cadaver studies, a lot of older people have vascular tortuosity. A lot of people here who see elderly people and do imaging see a lot of tortuosity. At least that's what adult cardiologists tell me. So we assumed it was getting worse with age, and this was an accelerated aging phenotype. And how do you use it? Do you say the more tortuosity you operate, or does tortuosity tell you to operate a smaller aortic diameter? Certainly I have newborns that have a ton of tortuosity. Does that mean we operate? How do we use it? So we've gone on to try to figure out what to do. So first of all, we looked at vertebral artery tortuosity over time, and we're quite surprised. So this is a study. If you look, these are patients with both Marfan syndrome and TGFBR1 and TGFBR2 mutations, and along the x-axis, this is age and this is height, and along the y-axis, their tortuosity, and every line is an individual patient. And as you can see, despite a couple of these that have really severe tortuosity, over 50 is severe. So, and I'll say this is probably measurement challenges. Overall, the trend is down with age, and actually it has a really strong correlation with height. So what we determined from this is it seems that you're born with the most tortuosity you're gonna have in these vascular mediated disorders, and then as you grow, you lengthen and you outgrow your tortuosity. And this was a good and a bad thing. The good thing was that, okay, great, actually, since it totally correlates with height, we can adjust for height. The bad thing is we just turned it into a static variable, if that makes sense. I just said how z-score doesn't change over the course of your life, so you can't follow it. Well, now we just made tortuosity something that doesn't change, index tortuosity doesn't change over the course of your life. It doesn't help follow someone, but now it's a different risk stratifier, if that makes sense. If you have high tortuosity, you have high tortuosity when you're born, you have high tortuosity when you're 30, if you index it for height, but it is an increased risk factor for dissection. It just doesn't change with time. We then reapplied this in a larger cohort looking at patients, and we were a lot more specific this time. This is looking at just type A dissections, and this is just for the ease of a Kaplan-Meier, we dichotomized between a height-adjusted tortuosity less than 68 and a height-adjusted tortuosity greater than 68, and we see much more type A dissections with higher tortuosity. But again, this doesn't sort of incorporate size. What do we do about size? We split this looking between both Marfan patients and TGFBR1 and TGFBR2. Now, we didn't have very many dissections in this population because these are children, so this was not significant, but you can see that the pattern, this was strongly significant, and the pattern is mirrored in the Loeys-Dietz patients, suggesting that even among the group that we think is more severe, those with lower tortuosity are more protected. So then we moved on to do some multivariable modeling and using time-dependent covariates. So what these are, this is it's a very old method, but I feel like we don't use it enough in our field, but it's allowing patients to sort of jump risk lines. We think of a Kaplan-Meier, you're on the top line, you're on the bottom line. But if you're pregnant, you can go to a high-risk line. If you're not pregnant, you can go to a low-risk line. If you're 42 today, you're on the 42-year-old line, and you're 41 yesterday, you're on the 41-year-old line. So it's a really nice way of modeling, and it's sort of infinite by doing time-dependent covariates. You're not making assumptions that someone has the same risk their whole life. And we looked at age, genotype, sex, BAV, pregnancy history, history of surgery, and history of dissection. And I don't have time to go through all the variables, but ultimately, when we did our multivariable model for type A dissection, 3 variables came out. So one, which we weren't surprised at, is height-adjusted tortuosity greater than 68, compared to less than 68, had a high hazard ratio. 2, we were surprised at, is a prior type B dissection without a root replacement at the same time. So these are retrograde dissections, and 30% of our patients who had a type B dissection and did not have their root replaced, this is within a group of patients with Marfan syndrome, TGFBR1 or TGFBR2 mutations, 30% had a dissection within 2 years. And female being peripartum. Now, I know this is probably a little inflated. I don't know if there's bias in our group of having so many women, but we did this about 9 different ways, trying to adjust for different things. And the peripartum female, compared to all others, had significantly increased risk when we modeled it this way. Now, when we did secondary analyses and we split, I'm peripartum versus never pregnant versus prepubertal versus I have been pregnant, but I'm not peripartum. The I have been pregnant in the past, just like other speakers, actually was significant as well in our secondary modeling with a hazard ratio of about 4, with the prepubertal girls being the lowest risk, obviously. And then we already talked about the prior type B. Now, just to give this a more visual for those clinicians in the room, which again helps me, this is a Kaplan-Meier sort of done in a different way. So we modeled what is the risk for dissection less than 5 centimeters? So this is a sub-analysis. We took all the patients in our cohort. We didn't have any patients that had a dissection less than 4 centimeters. So we took everyone who made it to 4 centimeters, who had any kind of imaging and any kind of follow-up at 4 centimeters. And that's where they started. They all started right here. And we said, do you have one of the 3 predictors, either tortuosity index greater than 68, pregnant, or you had a prior type B dissection without a root replacement. And if you look, along the x-axis is not time, it's aortic dimension. So we said, at what aortic dimension did you rupture, or did you dissect? So this is freedom from type A dissection. And if you look, in the low risk group who did not have these, not a single patient had a dissection before 5 centimeters. In fact, the first patient to have a dissection in that group was 5.6 centimeters. If you look in the high-risk group, starting immediately, they start dropping down, and they were equally represented in these 3 groups and start going down. And so for me, this is, basically suggests, again, the group cohort is not, this is about 200 patients, and it is multiple genes, that, despite your genotype, you can look at these risk factors to figure out who maybe you can operate on earlier or later than just using this magic 5 number. Maybe there's patients you don't have to be so aggressive in. So, and if we look at this, if we're looking at specificity for root dissection before 5 centimeters, the sensitivity is 100%, specificity is 60%. Positive predictive value, that means the number of patients that had the event, 30%, and negative predictive value, 100%. Tortuosity has been looked at by a few other authors. One of these is by the Franken group, the Dutch group. They looked at total aortic tortuosity in their secondary analysis of their RCT, and they looked at overall any dissection, although the majority of their events were type B dissections, and they did show that aortic tortuosity was associated with future type B dissection. I didn't show our data, but we have preliminary data showing the same. Also, we think that this is going to be a tool, this is preliminary, this is unpublished, a tool within families. A lot of people have talked about intrafamilial variation, about how someone can be really affected and someone else is not affected, but they have the same genotype. We think that these are modifiers in the family. Well, I'm thrilled that all of our translational researchers and basic scientists are finding the modifiers, but from a simple clinician's perspective, I want to know who's at high risk and who's at low risk. So we looked in this family and we said, did the tortuosity correlate with their severity? So along the x-axis is the family. These are 8 family members who range from having a normal aortic root to severely dilated aortic root. And we had 2 men with dissection and the rest did not dissect. And if you look, there was a strong correlation. This is overall aortic tortuosity. These are vertebral artery tortuosity. And this is just looking at who dissected. Our second guy did not make it on this because I just got his tortuosity index, but it was 75. You can see that the ones that dissected were significantly higher. And this is all in the same family with the TGF-beta2 mutation. So going on to other predictors, now we can talk a little bit about aortic stiffness. Now, as far as I know, there's been no, besides size and tortuosity, there's been no other predictors that correlate with human dissection. The rest of the predictors correlate with human degree of dilation. So we know that patients with connective tissue disorders have increased aortic wall stiffness, and in adults, increased aortic wall stiffness is associated with increased growth. So if we look here, we look at the mean annual change in the aorta, and the more stiff the aorta, the faster the aorta grows. We have certain measures of aortic stiffness, different ways to manipulate your numbers. You can use strain, sensibility, beta stiffness, pulse wave velocity. These can be done on both echo and MRI. And there is a paper, this is from Circulation a few years ago, looking in patients specifically, again, this is a mixed cohort of Marfan syndrome and TGFBR1 and TGFBR2 mutations. And they did show that patients, again, they did not have dissection as an outcome, but root dilation as an outcome. And patients who had lower strain, which is more stiff, were more likely to have a root replacement. And when we looked here, root strain correlated with the area of the aortic root. Again, we haven't had enough data. Again, this goes to multi-center research to look at the correlation with dissection. This is seen too in Turner syndrome. In Turner syndrome, they have increased aortic stiffness compared to other patients, but no one has been able to get a large enough sample to see if it correlates with dissection. Now, just a brief note on inflammatory biomarkers. Clearly, there's lots of animal data, some human data, that inflammation is an enormous part of this. But to date, as far as I know, there's no data for predictors of human events for inflammatory biomarkers, where you can sort of do a test and say your risk of dissection in the next 2 years is XYZ, but we're certainly looking for it. There is a study by Lynn Marshall and Lynn Sakai looking at fibrillin fragments, and what they did is they looked at patients who had an aortic aneurysm or did not, and looked at certain fibrillin fragments, and showed that patients with aneurysms had greater fibrillin fragments. However, again, this was not dissections. They did not predict dissections, so we still have a long way to go. As the last thing is looking at 4D flow, something I'm really excited about with the mechanisms, but we're still very limited in that we can look at really pretty pictures, we can look at helices, we can look at areas of dilation. They're very nice, but as far as I know, unless someone would love to come up and correct me or tell me about their unpublished evidence, I don't think we have any data currently that says this thing I measure on 4D flow is going to predict dissection, but we're all trying to get together and work on it. So just to summarize, risk factors that we know for dissection. For type A dissections, we know that male sex is associated, vertebral artery tortuosity, TGFBR2 versus TGFBR1. I think we all practice family history, but I don't think there's a single paper that actually says like you control people without a family history versus with a family history in a controlled manner. And then dynamic for type A is age, increasing root dimension, pregnancy, and prior type B. I didn't go over the B data. There's very little, as we all know. Bs are so hard to predict. They certainly is associated with age. There's a single paper saying it's associated with aortic dimension in the isthmus, but that's for 2.7 centimeters, which is over 50% of patients who get a CT. And prior prophylactic root surgery, as been mentioned multiple times, and we don't know whether the root surgery is causing it or whether we're just seeing a more severe population there. And perhaps thoracic aortic tortuosity, as suggested in that Franken article I talked about after the Dutch RCT. So upcoming risk factors for dissection, better differentiation between genes. Of course, we're hoping for the pie in the sky, modifying gene variants. These are both static variables, and for dynamic, arch and thoracic tortuosity, stiffness in a more usable way, as well as 4D flow, microcalcification, FBN1 fragments, and hopefully inflammatory markers will bear some fruit. Just a couple of slides on something we're working on. This is, if you guys have seen this is out of business decision tree analysis. The last couple of speakers talked about personalizing approach. We're trying to mathematically do that, where you can type in, as Diana also mentioned, your gene, your tortuosity, your root dilation, all of these information, and make a model. And this is just an example. This was at my part of a master's project I worked on, but you could put the inputs. This is, for example, a child who's 3 years old with a severely dilated root. And we ran 2 Kaplan-Meier curves. The blue one would be projecting if you did surgery now, but accounting for the risk of surgery, accounting for the risk of a prosthetic valve, accounting for the risk of anticoagulation if you get a prosthetic valve, or waiting till they hit 5 centimeters. And when you model it, for example, this kid, it shows that actually if you intervene, the risk would be higher. This is a model again, but would be higher than waiting to 5 centimeters. So basically, in summary, studies have been really limited in truly defining risk factors for dissection in genetically mediated aortic disease. A lot of it has been very heterogeneous. But increase in addition to age and aortic size, we can use VTI, pregnancy, and primary type B aortic dissection for looking at people who dissect less than 5 centimeters. And lack of those is actually protective. And management, as everyone in this room knows, is really complex, and we're going to need to keep working on more complex modeling. Thank you guys, especially to Dr. Milowicz for her amazing mentorship, and to everyone who has been very collaborative in donating studies to our imaging research. Thanks.
Thank you so much, Shaine. That's a very, very interesting talk. We have time for a couple of quick questions. Reed.
Shaine.
Yes, sir.
Thank you so much for leading this important area of investigation. You're teaching us a lot. A quick comment and then a question. And you've heard the comment before, and that is, in the States, it's virtually impossible for us to image the neck by CT or MR without ordering a neck CT or MR, which is a separate charge,
right.
And the insurance companies have no reason to approve that. So I'd love to be able to measure VTI, but I can't.
Well, we're hoping if more people adopt it. I know most pediatric centers in the U.S., most large pediatric centers in the U.S., I know of at least 10 have adopted doing this as part of their studies. And if we can get more data out there, maybe we can finally convince the insurance companies if we're using it as a risk stratification tool. But you're right, sometimes we get it for free because I'm one of the MRI people and I've convinced them to just add it to the chest. But you're right, most people will charge for it. Aortic tortuosity, I think it's not quite as predictive, but aortic tortuosity can be done easily.
Well, the advantage is kids have shorter necks. So
that's true, yes. And we use an extra large coil and just get them from here to here.
So the quick question, involves the pathogenesis of tortuosity. And it must differ from mutations to mutations because, as I think was mentioned earlier, perhaps from you, that people with the arterial tortuosity syndrome who have both carotid and vertebral tortuosity and amazing aortic tortuosity don't dissect.
Exactly, and we don't. You know who else has really significant tortuosity is children with Williams syndrome. And actually, we just had a paper at the AHA that showed that the degree of tortuosity in Williams syndrome correlated with the degree of coronary stenosis and ischemia, which was a big surprise. And so, I mean, I think all of these patients have disrupted elastin, and I don't know if that's reflecting that. It's unclear, but you're right. It obviously is modified by the gene, and why you get tortuosity seems to be different because those children do not dissect, and neither do kids with Williams, obviously.
Thank you. That was such a great talk.
Oh, thank you.
Just like you see a correlation in children with Williams syndrome with other phenotypic presentations, in non-FBN1 related aortopathies, do you have any data of whether tortuosity in the head and neck predicts risk of arterial involvements elsewhere, celiac, iliac, mesenteric, and things like that?
We haven't specifically looked. I'm certain that it does, though. I mean, when you see it here, when you see the tortuosity, like you can almost always, like the fact that at least you'll see tortuosity elsewhere. Aneurysms, children don't very commonly have extra cardiac aneurysms, but for sure if we see tortuosity in the brain, we're more likely to see it in the renal arteries. But as for aortic or other arterial aneurysms, I'd have to work with our adult colleagues because that's so rare in children.
Thank you.
Thanks.
Hi Shane, lovely talk.
Hi,
Just a few
thank you.
quick questions. Have you ever had the opportunity to look at fetal MRI and determine whether babies with these conditions have more impressive tortuosity in the...
I would love to, and fetal MRI is like when I do fetal, so I love fetal MRI. But unfortunately, fetal MRI doesn't have, you can't do vascular imaging yet on fetal MRI because, at least not close to the heart.
Yeah.
I mean, maybe this is far enough away, but we don't have angiography because it needs to be gated, and we can't gate fetal MRIs that well. Actually, Sick Kids here is one of the only places in the world they're doing this metric optimized gating to sort of gate, but I don't think their resolution is small enough to do vertebral arteries. You could probably do the whole aorta, but I think that that's going to be so subtle in a fetus because I think that actually progresses with time.
And post or peripartum woman, so postpartum woman, have you seen...
Oh, in a peripartum woman. Well, no, because I've looked at the vessels in 5 or 6 peripartum women, and 2 of whom dissected, but we didn't see a dramatic difference. I think that mechanism is totally different.
Yeah, I mean, it's interesting that elastin talk because we know that elastin gets laid down from sort of mid-trimester to about sort of 6 years of age. And I sort of wonder, I mean, similar to bony overgrowth, it seems that these vessels are growing longer than, and it's impressive that for the major branches, of course, the carotids and the vertebrals are closest to the heart, but everywhere, I mean, the corkscrewing is particularly significant in the vertebral canal, where every time it meets a bony orifice, so it seems to be a combination of both overgrowth and then some sort of resistance to flow.
Right, and it's hard to know if it's resistance to flow, or if it's just they're small enough that they can bend more easily, because it seems to be the smaller the vessels, the more they twist. But you're right. Yeah, thank you so much.
Shane, can I ask a quick question? So, fascinated by your tortuosity data, and particularly with respect to age.
Yes.
So you were surprised to find that tortuosity decreases with age. And as an adult physician, I find I have to, when I'm looking to see if the descending aorta and the iliacs are tortuous, I have to mentally calibrate for age, because older people develop tortuosity in the normal range. So do you think there's a U-shaped curve?
Yes, I think there's probably an aging-related increase in tortuosity that's normal, but we thought this was just accelerated aging, but I think they're totally different mechanisms of tortuosity.
Fascinating.
Sorry, Shane, I just missed one question. Do you know what the relationship between Z-scores and the...
They're correlated. It's not a super strong correlation. They're both independent predictors of outcomes, but they are correlated. And in fact, Dr. Dietz, is he still back there, had a paper out looking at cervical artery carotid tortuosity and time to root surgery, which obviously correlates with dimension. So they are correlated, yeah.